Hey guys, hope the studying is going well. This talk will be about musculoskeletal infection in the pediatric patient. I have no disclosures related to this talk. We'll go through the epidemiology and then we'll talk specifically about osteomyelitis and septic arthritis, and then we'll review a couple of special considerations at the end. In terms of the epidemiology of pediatric musculoskeletal infection, the annual incidence of bone and joint infections in kids in high-income countries like the US is 8 per 100,000. Most infections occur in the first decade of life, although half of infections occur in the first 5 years. Younger kids are more likely to present with septic arthritis. Older kids are more likely to present with osteomyelitis or a combination of MSK infection. Staph aureus is the causative species in about 90% of the cases, and then strep species are the second most common infectious organism. Now we'll go specifically to osteomyelitis. So this is defined as bone infection typically caused by a bacteria. In kids in the US, it's acute osteomyelitis is typically hematogenous in origin. It affects healthy kids, although those that are immunocompromised are at a higher risk. I've listed a couple of examples here. The annual incidence of osteomyelitis is 1 per 5,000 for kids under 13. Again, most occur in the first decade, half in the first 5 years. It's more common in males, and the osteo typically begins in the metaphysis of the long bones, and so this has implications for associated septic arthritis. The clinical presentation of a child with osteo will be localized pain. It's typically atraumatic in onset, although about 30% will have a history of minor trauma that you can elicit. There will be limited use of the affected limb, so kids may splint the upper extremity, or the lower extremity may be held preferentially in flexion, abduction, and external rotation. Fever may be associated as well as a systemic illness. You may see other changes in vital signs, especially in more advanced cases. The affected area may be swollen, warm, red, and tender to palpation. If there's also involvement of joints, there may be limited passive range of motion. And then remember always to examine the entire ipsilateral limb when you're concerned for an MSK infection in a child, as well as the contralateral limb, so you'll have a baseline. Differential diagnosis for osteo includes soft tissue infection like cellulitis or pyomyositis, septic arthritis, although osteo and septic arthritis can and do often occur together, fracture, non-accidental trauma, malignancy, or a sickle cell associated pain crisis or bone infarct. In terms of additional diagnostic imaging and labs, we usually start with x-rays. We consider x-raying not only the affected but also the adjacent bones, and then a contralateral side may be helpful for comparison purposes. An MRI with and without contrast I do think is still will be your test answer, although our MRI imaging capabilities do continue to improve. We like to do this early when we're concerned about osteomyelitis. And then labs, CBC with diff, a CRP, an ESR, and blood culture, and occasionally a bone or tissue culture is requested, usually by the ID team if we're concerned about a child who's not improving or they really want to tailor antibiotic treatment. X-ray findings early on may include soft tissue swelling, which appears within 48 hours, and then we will start to see new periosteal bone formation and periosteal elevation within 5 to 7 days. And then later we'll see osteolysis, lytic or permeative changes in cortical disruption, which may appear within 10 to 14 days. And you can see on the X-ray that I've pictured here, actually all of those changes are present. Again, MRI with and without contrast is very useful for evaluating osteomyelitis. It helps additionally identify any other MSK infections when present, and the extent of them, and this could include a subperiosteal abscess, pyomyositis, or an intraosseous abscess. MRI is very sensitive and very specific. Its disadvantages really are its cost, access, and then the requirement for monitored sedation in young kids. And so ideally we do MRI with contrast as a multidisciplinary team involving the MSK radiologist, the anesthesiologist, and the orthopedic surgeon. And ideally, we go right from the MRI suite to the operating room to treat all associated infections. In terms of lab studies, so the ESR, so this is the rate at which erythrocytes fall through plasma. It's most influenced by serum fibrinogen and other acute phase reactants. The peak ESR occurs within 3 to 5 days of the onset of infection and then slowly returns to normal over a period of maybe 3 weeks. The CRP is also an acute phase reactant, but it is more responsive, and so its levels begin to rise within 6 hours of a triggering stimulus. It peaks within 36 to 50 hours and then resolves within 7 days in uncomplicated cases that receive appropriate treatment. In terms of the microbiology, again, Staph aureus is most common, and again, this can be MSSA or MRSA, followed by beta hemolytic streptococcus species, and then Kingella, I think, is increasingly tested. It is increasingly prevalent, although notoriously difficult to culture. And then special situations include strep, which we may see in unvaccinated or asplenic kids, H. flu, again in the unvaccinated population, Salmonella we think about with sicklers. For those who live in developing countries or who have a recent travel history, we may think about Mycobacterium tuberculosis, Brucella, or Salmonella. Cat exposure may be Bartonella. Neonates may be Group B strep or Neisseria gonorrhea, which may also be seen in adolescents. Talking more specifically about Staphylococcus aureus, so again, this can be MSSA or MRSA, and that may be community acquired. This is often associated with the PVL gene, Pantin-Valentine leukocidin, also highly testable, responsible for the cytotoxin that is destructive to tissues. And so kids who are infected with this species tend to present with more severe infections that are more difficult to treat. And so they may require multiple surgical debridements. They may require ICU admission. They may develop DVT or septic pulmonary emboli. And in general, these children are just much more sick. So a summary of the initial evaluation for suspected osteomyelitis is listed here. And this is just everything that we've talked about. In terms of treatment, uncomplicated osteomyelitis is treated medically after blood cultures are drawn, and this means beginning empiric IV antibiotics, which cover both MSSA and MRSA. Again, a multidisciplinary treatment team is useful, including pediatrics, infectious disease, and occasionally hematology. The child's response to medical treatment needs to be monitored, meaning we follow their temperature curve, their vital signs to be normal. We expect pain and function to both improve. Elevated inflammatory markers should trend to baseline, and blood cultures should become and remain negative. Complicated osteomyelitis may require surgical treatment for drainage of abscesses in the soft tissues, subperiosteally or intraosseous abscesses, and also for drainage of associated septic arthritis. You can see depicted here is a subperiosteal abscess of the metatarsal, so there's involvement of the bone with osteomyelitis, and then a big collection of pus, which is elevating the periosteum away from the bone, which requires surgical drainage for treatment. And this is just an example of an intraosseous abscess of the distal tibia and an intraoperative fluoroscopic image demonstrating curettage or IND of that intraosseous abscess. So failure of clinical markers of infection to improve requires additional testing or treatment. And so this means if a child has persistent fevers, persistent elevation of the CRP or white blood cell count, or persistently positive blood cultures, and these findings should prompt investigation for persistent or additional sources of infection, such as endocarditis, a DVT, persistent or recurrent local infection, or a skip lesion, meaning distant or secondary sites of infection. In general, outcomes for uncomplicated acute hematogenous osteomyelitis in kids are good, with complete resolution and no sequelae in the long term. However, complications do occasionally occur, and these may include chronic osteo, a MIST-associated septic arthritis with resultant joint damage and osteoarthritis, Pathologic fracture either through infected bone or through your surgical corticotomy if you have treated it surgically, and then growth disturbance if the physis has been affected either with the infection or with surgical treatment. And just a word about chronic osteomyelitis. This is rare in the U.S. because typically a musculoskeletal infection is promptly recognized and treated. Chronic osteo may be defined as infection present for greater than 6 weeks. Again, usually it's the result of delayed presentation of an acute hematogenous osteo. Radiographic features include the presence of dead bone, that's the sequestrum, and reactive new bone, that's the involucrum. And draining sinuses may erupt as the rapid expansion of infection erodes through the overlying tissue planes. And here you can see an example of a chronic osteomyelitis of the proximal femur with demonstrating on this radiograph both the involucrum and sequestrum. We'll move on to septic arthritis. So this is an infection, usually bacterial, that occurs in a closed joint space. In kids in the U.S., it's the hip and the knee, which are most commonly affected. Hematogenous spread is typical, although local trauma or direct inoculation are also described. Direct extension into a joint from osteomyelitis, which affects the metaphysis and the adjacent bone, is common. And so joints that have an intra-articular metaphysis are most affected. This is probably a highly testable question, and so the 4 joints with an intra-articular metaphysis are the shoulder, elbow, hip, and ankle. You'll note the knee is not one of them, although it is also commonly affected by septic arthritis. Septic arthritis may occur in isolation, although it is increasingly common for it to occur as part of a more complex osteoarticular infection, meaning the additional presence of osteomyelitis or abscess. Early recognition and prompt treatment are key for good outcomes for septic arthritis. This is one of the true orthopedic emergencies, and this is because we would like to prevent the cytokine-mediated articular cartilage damage done by the proteolytic MMPs and then the resultant irreparable joint destruction leading to end-stage arthritis. A child presents clinically, a child who has septic arthritis presents clinically probably with the acute onset of fever. They may again be systemically ill, have malaise. They may be irritable or lethargic with a decreased appetite. Typically, they'll refuse to use or bear weight through the joint that is affected, so they may limp, or you'll note pseudo-paralysis of an affected upper extremity, and you always want to take a vaccination history. On physical exam, the child may be febrile, and again, in more advanced cases, tachycardic or hypotensive. They may be ill-appearing. We talked about this positioning of a lower extremity, maybe flexion, abduction, and external rotation. If it's the hip that's affected, the upper extremity may be splinted by the child. Passive range of motion of the affected joint is quite limited. I think this is actually a hallmark finding of septic arthritis. And then again, you always want to examine the entire ipsilateral limb as well as the contralateral limb for comparison purposes. The differential diagnosis of septic arthritis in a child is listed here. The 5, I would say, main categories include traumatic, meaning fracture or even non-accidental trauma. Inflammatory, which includes transient synovitis or a juvenile inflammatory arthritis or a post-infectious arthritis. Infectious, meaning there's associated bacterial infection in the musculoskeletal system, like an abscess or osteomyelitis. Viral arthritis, Lyme arthritis in endemic areas, or even tuberculosis. It can be other musculoskeletal conditions like LCP or PVNS or even tumor, or especially again for the hip, hip pain and limp in a child may actually be due to non-musculoskeletal conditions like appendicitis, pyelonephritis, or genitourinary infection. One of the big things in pediatric musculoskeletal infection is trying to differentiate a toxic synovitis from septic arthritis, and so the modified Kocher criteria I've listed here. So the original 4 were a fever greater than 38.5, the inability to ambulate, a white blood cell count greater than 12, and ESR greater than 40, and then the modification of this is a CRP greater than 2. So again, the 4 original Kocher criteria do not include the CRP, and I've listed here their predictive ability. So if only one of these criteria is present, the risk of septic arthritis being present is less than 3%. When 2 of the predictors are present, this goes up to 40%. With 3, it goes up to 93%, and with 4, 99%. And that said, it's actually the CRP and fever are the most sensitive predictors of a child having septic arthritis. Diagnostic laboratories are similar to those done for osteomyelitis, the CBC-Diff, CRP, ESR, and blood culture. You may consider a Lyme titer in an endemic area. What is different is that we want to do a joint aspirate, and this is done prior to the initiation of antibiotic treatment. So we look at the cell count and say that if there are greater than 50,000 white blood cells present, we're concerned for septic arthritis, especially if greater than 3/4 of them are PMNs. And then we do a gram stain and culture and sensitivity, and a positive gram stain is diagnostic for septic arthritis. Our diagnostic imaging, so we do orthogonal radiographs of the affected bone and joint, and then adjacent, and then this is an example of contralateral. You can see these x-rays are old because these are actually pictures of x-rays, but you can see in the image on the left that there's joint space widening. The proximal femur is actually laterally displaced, and you can actually see the soft tissue inflammation within the joint. Ultrasound has basically become, I think, standard of care. So this is low cost, it's non-invasive, there's no radiation involved, it's portable, and there's minimal sedation needed. And these are all true benefits to the use of ultrasound. It may be useful in differentiating musculoskeletal infection that's not within a joint or bone, but is maybe an abscess intramuscularly. It is especially useful for localizing fluid in joints, such as the hip, for aspiration, and ultrasound-guided aspiration can be done in the ER. And again, this is especially useful because it allows for earlier initiation of empiric antibiotic treatment, as well as ease of diagnosis for septic arthritis. MRI with and without contrast, just like for osteomyelitis, is also very useful. This helps us identify associated MSK infection, which in turn helps with surgical planning. Although I would add that, again, this needs to be done in a way that is multidisciplinary, using teamwork with anesthesia, radiology, and orthopedic surgery, and that because a child needs to be intubated for MRI, if access to MRI cannot be done in a timely fashion, but you are confident that septic arthritis is present, then surgical treatment of that is likely warranted rather than continue to wait for an MRI available. The microbiology is the same for septic arthritis and osteomyelitis. And I've listed here just a summary of the initial evaluation, which we've just reviewed. And then the treatment is emergent surgical IND. So this can be done open or arthroscopically, although some might argue that, that arthroscopic hip IND is the triumph of technology over reason. It is increasingly being done. At the time of surgery, you're going to address any known concomitant MSK infection, and then again, you're going to do empiric antibiotics as soon as cultures are obtained. If you're not in an institution where ultrasound-guided hip aspiration can be done in the emergency room, you're likely going to start with this in the operating room, and that's what this clinical image is showing, is a fluoroscopic-guided hip aspiration. In terms of antibiotic guidelines, so you're going to tailor your choice of empiric antibiotic by the child's age, the history you've elicited, especially whether or not he or she is vaccinated, and local epidemiology patterns. And again, an infectious disease consult, it can be quite helpful with this, not just determining which antibiotic and which route of administration, but also duration. And I've listed here some suggested guidelines for empiric antibiotic treatment of MSK infections in kids. Complications of septic arthritis include physeal injury, which may result in a limb length discrepancy or angular deformity. Kids may end up with hip laxity, which can lead to subluxation or even dislocation. I didn't list it here actually, but conversely, the hips can become stiff. Osteonecrosis may develop if there is an injury to the vessels. And then the end result of many of these processes may be arthritis. All right, lastly, we'll just review a handful of special situations, the first of which is Lyme arthritis. This is important to know about because it is a close mimicker of septic arthritis, and in fact, children who have presented with Lyme arthritis may have lab values as high as the ones I've listed here. So white blood cell count as high as 22, a CRP as high as 7, ESR as high as 94, and a cell count as high as 158,000, and all of those would be diagnostic for septic arthritis. Clinically, however, when you look at a kid who's got a Lyme arthritis, typically they're still ambulating. Passive range of motion of the joint is fairly well preserved despite the effusion that is present, and they're not ill-appearing. And those are all helpful in terms of teasing out a Lyme arthritis from a septic arthritis. And it's important to do so because the treatment is different. So the treatment of Lyme arthritis is antibiotics rather than surgical line. Neonates are another special situation. So MSK infection in a neonate occurs in as many as 3 per 1,000 NICU admissions. Children this age may have a very subtle presentation of infection, which leads to a delay in diagnosis and ultimately to poorer outcomes. Some of the signs may be pseudoparalysis of a limb, anorexia, or lethargy. A child this age may not mount a fever, and similarly, standard labs may be unreliable. The organisms that cause MSK infection are different in this age group, and they may include group B strep, Neisseria gonorrhea, and GNRs. And again, kids this age with MSK infection have worse outcomes than we see in older children. Discitis, and I've shown here a sagittal MRI of a child with discitis, may occur in kids less than 5 years. Most commonly, it affects the lumbar spine most commonly. Staph aureus is usually the causative organism, and treatment is antibiotic therapy, and then oftentimes we'll add a brace as well. Sickle cell disease. So a sickle crisis may mimic an MSK infection as a child presents with pain, fever, swelling, and elevated inflammatory markers. That said, kids with sickle cell are also more prone to MSK infection, and Staph aureus is still the most common causative organism, although you have to also consider less common ones like Salmonella in this population. All right, so pearls to leave you with. MRI with or without contrast remains the gold standard for diagnosis of osteomyelitis, and it's especially useful for identifying associated MSK infection, again, like a subperiosteal abscess that may also require surgical treatment. Empiric antibiotics should be initiated as soon as cultures are obtained and should target Staph aureus, both MSSA and MRSA. The 4 joints with intra-articular metaphyses are more prone to septic arthritis associated with osteo, and these are the shoulder, elbow, hip, and ankle, and not the knee. Limited passive range of motion of the affected joint is a key physical exam finding for septic arthritis. The Kocher criteria to differentiate transient synovitis from septic arthritis are fever, white blood cell count greater than 12, ESR greater than 40, and the inability to weight bear. A CRP greater than 2 and a fever greater than 38.5, however, are the best clinical predictors for the presence of septic arthritis. And ultrasound-guided hip aspiration done in the emergency room is very useful for enabling earlier diagnosis and initiation of empiric antibiotics, and is becoming the gold standard of care. And one of the pearls I didn't list here, but I'll just say again, is that kids who present with an MRSA infection are invariably sicker. They may develop less usual sequelae, including a DVT or septic emboli, and they are more likely to require repeat trips to the operating room to thoroughly treat the underlying infection. And I will leave you. So thanks to you all, and good luck.